Hi,
Thanks
Lily.
for having me back. We'll talk some more. Let me share my screen. All righty. Excellent. So, similarly to everything we talked about before lunch, um, we really are going to just talk about things at a very surface level because we don't have a ton of time to talk about all of these things in depth. And we could talk about everything very much in depth, but I am hoping that just kind of at least discussing everything a little bit will, again, make sure you guys have heard of these things. Make sure you keep them a little bit in mind when you're dealing with patients that have been traumatized. And then maybe if you see any specific topic that is something that you're really interested in, you can do more research, or is something that you think would really help OVAG. Maybe we can work on having some future sessions on specific topics. But so today I'm going to talk about trauma, but what I'm really talking about is not your simple run-of-the-mill laceration or abrasion. We're really going to be talking about very large scale trauma, usually what we would call in English polytrauma. So multiple types of trauma all at once. Things like crush injuries, all of these can be really, really severe and cause a lot of problems and lead to systemic multiple organ function dysfunctions and issues. And so we're just gonna, again, unfortunately, I cannot dive into anything super deep. We're just gonna kind of skim the surface and talk about a few things with trauma. But feel free to stop me if you have questions. And again, we will have all these slides available for you. And I'm always happy to take any questions with email or WhatsApp if you want to talk about things further. I will never stop with my do your triage exam caveat though. So just again, even in the animals that have polytrauma and multiple traumatic wounds and things, if they aren't able to breathe, if they aren't able to circulate their blood, if their neurologic system is shutting down, we're not going to be able to save them from their polytrauma. So definitely always again, start out with your triage exam. And then when you do have an animal that comes in with a lot of severe trauma, we are going to want to start trying to get some tests done on them pretty quickly. In human hospitals, but definitely not veterinary hospitals, they're always going to send them off for a CT scan to get a complete look on what's going on in their body. But I know that's not often the case for something that we can do in veterinary medicine and with our wildlife and orangutan patients. And I think that is actually okay. I think when we are trying to triage an animal, figure out what's going on and figure out what is happening, I really want to advocate for us to use our fast scans. So I know that I talk about ultrasound a lot with us, and this is absolutely the perfect situation and perfect time to utilize your ultrasound. And I know it's not going to perfectly translate from English into Indonesian, but FAST, is an acronym in English. It means doing something quickly, but then the FAST stands for focused assessment with sonography for trauma. So really, we started using ultrasounds in the emergency room for trauma. We have now used it for a lot of other things, but it really is the first instance of where we can utilize ultrasound and learn a lot of really important information for our patients. So hopefully you guys remember somewhat some of the ultrasound uh, fast scanning we talked about for our thorax last year. We'll just go over a few of those slides again, and we'll also talk a little bit about the abdomen, so your abdominal focused assessment as well. But essentially, what we're doing, you want to just do it in a very systematic manner. So you want to look at the exact same spot on every patient every time just to look and see. And if you remember last year, we really are just trying to ask yes or no questions with our ultrasound. And the question is there free fluid or not? Is there free air or not? Those are the big questions we're going to ask when we are doing an ultrasound assessment for trauma. Obviously, we can look at a lot of other things with ultrasound, and that can be very useful. We can talk about one of those things for looking at our intracranial pressure a little bit later, but right now we're just gonna kind of hit 4 places in the abdomen and 4 to 8 places on the thorax to look for fluid and look for air. So one thing we might find with trauma is that we can't even really see any of the organs underneath because we might have subcutaneous emphysema. So if we have air under our skin or within our musculature, that air is not going to transmit the sound waves that the ultrasound is sending out. And oftentimes we can tell that there's subcu emphysema with our fingers when we're doing our physical exam. It'll feel kind of crinkly on the skin, but not always. Sometimes if you have deep air in the muscles, you might not necessarily be able to feel it that well. And so you will be able to see that on ultrasound. It's essentially just gonna look like this image here on the left where there just really isn't an image, and that's because the air isn't transmitting the sound. And that is a very important thing to know if there's air deep in your tissue. So your ultrasound can help you figure out that if that's happening. They also, if you have air under your skin, you might see something called a Z line, which is just this short little white line that will emanate down from the interface where that air hits your ultrasound. And again, we can just ask questions as we move through our lungs. Here is a pneumothorax. So instead of air in under our skin or under our muscles, if we have air around our lungs, we will see something similar where we might have Z lines and essentially no lung parenchyma being seen on the ultrasound, but we can see our skin and our muscle up here. So we know that the air is not under our skin or muscle, but is rather around our lungs. And again, this is a review from last year, but for those of you that weren't there, very, very quick review right there. Then our first question is there air? Our second question can be, is there fluid? Obviously, we have fluid in our organ systems normally. So in our heart, in our gallbladder, in our GI tract, in our bladder, we should have fluid, which is going to look black on ultrasound. So this is the heart here with fluid in it, and that is normal. And if you guys remember from last year, our trick with ultrasound, which is accurate most of the time, not 100% of the time, but most of the time, if there is fluid outside of an organ or fluid somewhere where it's not supposed to be, it's going to have angles. So this is fluid that we have here in our pleural space. It's surrounding our lungs, and you can see that there are angles. It looks like a triangle, and that's because it is fluid outside of an organ system where it's not supposed to be, and it's kind of working its way between organs. And so there are sharp angles around that fluid while it tries to seep into the different spaces between the organs. Whereas the fluid that we have in our heart, which is normal and should be there, is round. It doesn't have sharp angles. And again, our gallbladder, our GI tract, our heart, our blood vessels, our bladder, those are all going to be relatively round or have no sharp angles when there's fluid within them in a place where they're normally supposed to be. So we don't have to be super experts for us to be able to utilize ultrasound to assess for traumatic issues. We can really start off with very simple yes, no questions. Do we see black that is associated with fluid? And is that fluid pointy, meaning it might be outside of an organ where we're not supposed to see it? Or is it inside of an organ with smooth edges? And then we can get to more complicated things like checking with ultrasound to see if is fluid in our lungs. I think we'll come back to this one though, just so that we have enough time to cover everything. But you can answer a lot of questions with ultrasound. And when we're looking for all of these issues with our lungs, whether through x-rays or through our ultrasound, I just put this chart that we went over last year back on here as well for you all to look at. We obviously don't have these charts for orangutans, but just to give us kind of an idea of if your orangutan disaster patient has blunt trauma to its thorax. So did it fall out of a high tree or get hit by a car or something that caused some blunt trauma to its thorax? What is the likelihood that it has any of these issues going along with it? So, 58% of the time, if a dog has that happen, it's going to have a pulmonary contusion. And it's less likely to have air in its mediastinum, but it still happens 8% of the time. So just in case that is helpful for you or something that helps you keep in mind what you might be looking for, I have that there. And here's just that table continued with other possible things that you might find. I did want to talk a little bit about pulmonary contusions or just remind everybody about these that we talked about last year. So a pulmonary contusion is basically a bruise in your lung. So your lung got hit because you got traumatized and you bled into your lung. And so with the blood in that part of the lung, you aren't able to breathe in that area because there's no space for air to move and travel between your lungs and your airspace. Pulmonary contusions should be able to heal on their own without really any treatment, except sometimes the treatment we need to give is some pain medication or some anti-anxiety meds and or some oxygen to help them breathe. And if you remember, we talked about last year, they could get worse before they get better, because if you remember, right after you get hit on the arm or something, you don't immediately have a bruise. The bruise shows up a little bit later. And that is kind of similar to pulmonary contusions, where about 24 to 48 hours after the hit by the external force, that's usually when your pulmonary contusions are the worst. So you do have to watch any patient that you think has lung bruising very closely, because they might get worse before they get better. And then moving beyond our thorax, we also can check in our abdomen to look for any fluids. So I'm going to run back here really quick just to show you. So we usually check 4 spaces in the abdomen. One, which is called the subxiphoid, just right under the end of the sternum. We're looking kind of at our liver and stomach area, and we look back at our diaphragm. And then we look at both of the areas around the kidney on the left and right side of the body. And then we look down at the pelvic area around the urinary bladder. And so what we have here is an ultrasound where we're looking at the urinary bladder. So again, this is a fluid within an organ where it's supposed to be, so there's no sharp edges to this. And it's really useful in our trauma patients to see if organs are intact, because sometimes, unfortunately, when we get hit hard enough, we can rupture our bladder, we can rupture our gallbladder, we can rupture our stomach. Things can just, yeah, pop basically. And so if you can see an intact bladder, that's always a really great thing. But we can also see that there is some fluid outside of our bladder. And again, like we have talked about before, there's sharp angles to this fluid. So we know that that fluid is outside of any organ system. And the reason that we're doing this quick ultrasound on our abdomen and just looking in on our abdomen is because we want to know if there's fluid in the abdomen. We want to be able to sample it and monitor it. So sometimes you're only going to see a little bit of fluid, like what we're seeing here. And we might not be comfortable trying to get that fluid. If you guys remember 2 years ago when we were working on using ultrasound to help us poke things and get fluid, that is a really helpful thing to be able to do after a trauma. If you can use your ultrasound and find fluid, you can stick your needle in and get a little sample of that fluid. Most of the time, it's probably going to be blood because you're having some bleeding from the trauma, but it's not always. Sometimes it's urine, sometimes it's bile, sometimes it's GI contents. So it is always important to be able to get a sample of that if it's possible, just to make sure what's going on. And then also, it's always good to look at it and then track it over time, because if you have had a liver lobe that is pulled off of its blood supply, or if your spleen has a laceration and is ruptured, you can get a lot of blood into the abdomen really quickly. And so if you're seeing some blood, you might want to kind of wrap up the abdomen to try and put some pressure on it. And then you're going to want to recheck that ultrasound, looking at those same 4 spots over time. And if it's really continuing to fill up and gets a lot more blood, then we might be talking about needing to take that patient to surgery to try and stop that bleeding, or also talk about blood transfusions or something like that to try and replace that stuff. And we talked about blood transfusions 2 years ago. So just trying to tie all of our emergency critical care applications all together. And this is just another example of an ultrasound of the abdomen that has fluid. So this is a liver and a kidney, and then here's some sharp angled fluid around it. And this was a patient that was hit by a car and they were bleeding from their liver. Okay, so that is kind of our very, I would call it straightforward trauma, or things that we are expecting. If we fall from a building or a tree, or we get hit by a car, or we get crushed by items in a landslide or anything like that, it just does kind of make sense that we might have air under our skin, or we might have air from our lung popping, or we might have fluid from an organ popping, or from blood coming out of a bruise or rupturing a vessel or something like that. That is all pretty straightforward. It's not ideal. Obviously, we don't want our patients to experience that, but it's what we're kind of used to, or are thinking about when we deal with a patient with a lot of trauma. But there are a lot of other really sneaky things that happen when we get patients that have really severe trauma that is just not obvious right away. One of those is spinal instability that is unmasked. So we have a slide on that in a second. Another thing is physiologic degloving that doesn't declare itself right away. We also have a slide on that we'll go over on a second. And then the third thing that I don't have a slide on, so we'll cover it here a little bit, is crushed or saponified fat leading to abscessation. And so this is another kind of tricky, sneaky thing that you wouldn't necessarily always think about with trauma. But if you have a patient that gets crushed or gets hit really hard, and the fat in their abdomen gets twisted and cut off from the blood supply, or if it gets crushed really hard and gets cut off from its blood supply, it is actually not uncommon for that fat to just die off because it's not had any blood supply or anything. And that's a somewhat slow process that doesn't make itself super obvious to you. And again, usually this is fat that's hiding in the abdomen or something, so you're not looking at it visually and able to watch it like a wound that's on your skin or something like that. And also, somewhat frequently, when you get traumatized, you might damage your liver, so your liver isn't able to kill all of the bacteria that travel into the liver normally from the GI tract, or maybe you got really low blood pressure from the trauma from bleeding out, so that allowed some bacteria to escape your GI tract, or maybe you have a really large wound that also happened during your trauma, and so there's some bacteria that were able to kind of travel down deep into that wound and get into the blood supply. And so that bacteria might circulate around and find that saponified fat, which is a really, really nice thing for those bacteria to be able to eat. And so that can be a really insidious and tricky thing that you don't even know that is happening. If you have a patient that has really severe trauma, they come in, they're really sick, they're really not doing well, but you guys work really hard as you always do and make really good choices. You give them pain meds, you resuscitate them with fluids, you bandage any wounds, you set any fractures, you do all of these things. But then 5 to 10 days later, they're getting a fever, they're acting really, really sick, and you just cannot figure it out. One of the things that sometimes happens is that you've actually got a dead fat abscess inside the abdomen, and it can be so, so hard to pick up on and realize that it's happening. Other things that can be hard to pick up on is physiologic degloving. So if you guys remember from veterinary school or wounds or whenever you were taught about them, degloving, when we talk about degloving, that is usually something we're talking about anatomic degloving. And so what that means is your skin is completely pulled off of a tissue. So there's no tissue anymore. So usually we talk about like a finger degloving. And so all of the skin from the finger is gone, or a tail degloving. All the skin from a tail is pulled off. That is what's called a degloving. It means that the organ that is being supplied by that blood supply is no longer attached to that blood supply. And so anatomic deglovings are very obvious and really unpleasant looking usually, but you know that they have happened, and then you have to work really, really hard to try and improve that wound for that patient. But physiologic degloving is a lot trickier to find out what happened. And basically, what physiologic degloving means is that that organ stays in place, but the blood supply has been cut off. And this happens a lot if an animal gets run over slowly by a vehicle, for example, a crush injury. And if the wheels on a vehicle slowly back over a creature, obvious, there are other ways that this can happen as well, but the shear force will kind of shear the skin or maybe the piece of intestine in the abdomen or something off from the blood supply below. And then once the wheels come off of that animal, it didn't actually take the skin off. And so but the skin was ripped to the side enough when that wheel was running over it that it was pulled off the blood supply deeper to it. So over here you can see here where maybe this upper portion of the skin was maybe pulled to the side for a second while that animal was run over by the car, and then it snaps back into place. But then everything up here is going to die off because it was pulled off of its blood supply, but you just don't know it yet. So that's known as physiologic degloving, and that can take 2 to 7 days to show up. And it's not going to hide like the saponified fat inside of your abdomen. You'll be able to see it if it's a skin degloving. Although I have had a few cases that were really unfortunate because it really did have happen like on an intestine or in an organ inside the abdomen, and that can be much harder to find. But yeah, that is something where you don't want to forget if you know of an area that was crushed or you know of an area that was rolled over by a vehicle, you want to keep an eye on that really, really closely because in a few days it might be actually much worse in that area because that area is dying off. And that can be a really, really hard wound to deal with if you have an entire abdomen of tire tracks that you have to deal with dead skin on it. And another one to just quickly indicate, we'll talk about a little bit more very briefly at the end about monitoring neurologic status. Obviously, we could go into so much on testing for neurologic function in trauma and such. But another really tricky thing that I have seen in these really severe trauma cases is that originally sometimes we all, veterinarian doctors, will test neurologic status for a patient. And we will say, oh, they have intact full neurologic status. They can feel and move their legs, their arms. That is great. You know, we were really worried about it because they did get hit by a car really hard in their abdomen, or maybe again, they dropped from a tree really, really high. And so we were really worried they were going to break their back. And we will say, oh, but no, their spine seems intact. Everything is working. And unfortunately, sometimes 2 to 3 days, maybe even one day after the trauma, we will find out that they actually lost the ability to move their legs and they lost neurologic function. And what seems to happen in these cases is that we actually have a lot of muscle around our spine that's really supporting our spine. And so even if the bones around our spinal cord are broken, for a brief amount of time when there's a lot of adrenaline and the patient is trying really hard, they can actually support those broken bones and keep them in correct alignment. But their body is just not going to be strong enough to always hold that in place with those muscles as they deal with the trauma and battle with the trauma and, you know, eventually have to sleep and things like that. So unfortunately, also sometimes we can see in a couple of days the loss of a neurologic function if a really severe trauma happened and they were holding their spine in place with their muscles, and then we lose that ability. So it's definitely really important for the first few days, if you have a patient that had a lot of trauma, to check in on their neurologic status each day to just make sure you're not seeing a deterioration. Always unfortunate if and when that happens. Some other things that can happen when we have really, really severe trauma that I kind of hinted at earlier, because this can happen with our burn wounds and other items as well, is the rest of our body really gets feels the consequences of the massive trauma and the massive muscle damage that we have experienced. So our muscle is made up of myoglobin, which is that protein that gives our muscles kind of that red appearance. And when it is released from the muscles that are damaged, it forms radicals, it combines with calcium and other substances in the body. And those substances make a hard concretion, and that hard concretion goes to the tubules of our kidneys. So here's a picture of that. All of it concretes and goes into the tubules of the kidneys, and that pigment directly damages the tubules, and then it also gloms on. It becomes like a big sticky mess and gets stuck in the tubules. And also sometimes calcium is released from the muscles because the muscles require a lot of calcium to help them contract, which also can then go around and metastatically calcify things throughout the body. And since our kidney helps us regulate vitamin D and regulate our calcium, it can really struggle when it's dealing with all of these issues. So we definitely have to, like I said, monitor the color of our urine and monitor our urinary production, and monitor our kidney values really, really closely in those first few days after a trauma, because unfortunately our kidneys can shut down pretty quickly when it has to deal with a lot of muscle breakdown. In addition, we can also experience trouble clotting. There is this thing called the lethal triad we're going to go over in a second, but when you get cold and your blood gets acidic because your kidneys are shutting down and because so many waste products from your broken down kidneys are going, or your broken down muscles are going into your blood, this can all go together and can lead to your blood not clotting correctly, which is obviously a big problem if you've had a trauma and you're bleeding from that trauma. Then you can lose a lot of blood, and then you get very sick, and it's very, very hard to save a patient once they have the lethal triad. If they have acidic blood, if they're cold, and then if their blood starts not really clotting, it is an uphill battle to get them better. So that muscle breakdown that damages your kidneys, it causes a lot of issues that we've kind of already talked about. In humans, they start worrying that this might happen with when the creatinine kinase gets greater than 1,000 units per liter. And that is actually not that high. I don't know if you guys, what you guys experience or what you're seeing on your blood work, but I feel like any of our animals just even are upset a little bit that we have to dart them or inject them or handle them for an anesthesia or for an exam, and they can get a CK of 1,000. So usually it's something even higher than that when we actually see true problems from their muscle breakdown. But it is definitely still possible even at levels of as low as 1,000 creatine kinase being released into the blood. How do we treat all of this? One thing that we really recommend, I think you guys have this. I feel like I asked some people once and you guys said you had this in Indonesia, but if you do not, we should talk about if there's anything else we could come up with for you guys to use. But mannitol treatment is a really good idea. So mannitol is kind of a really large sugar molecule. And we would want to give this when we think that our muscles have been crushed. So if your muscles have really been damaged and crushed, then they are going to get swollen. There's going to be a lot of blood and nutrients that are going to rush to the muscle, and you can get what's called compartment syndrome. So basically, your muscle can only swell so much because you have fascial tissue planes surrounding your muscles, and if the muscle gets too swollen and it's not going to be able to keep all of that within that fascial tissue plane, then your muscle can die off because it's basically too squeezed in there. And then, of course, that's even worse. Our muscle is going to leak even more muscle problems out into the blood. And then it's going to go to our kidneys. It's going to shut down our body. It's going to be really not good. So if we can give mannitol, which if you guys have ever worked with mannitol, it's a little finicky. It really likes to precipitate out of the solution in the bottle. So you have to make sure you keep the mannitol really warm and really well mixed. You got to treat the mannitol really well, baby it a little bit, and give it with a filter, but you give a 0.5 gram per kilogram of mannitol IV. And that large sugar molecule is gonna pull out some of that extra fluid that's in your muscles. And also the really large sugar molecule, it kind of acts like a battering ram, and it goes in and it punches out all that really glommed up concreted muscle stuff that's stuck in the kidney tubules. So it punches that out. It also, because it is a sugar molecule, it seems to just make the heart a little happier and helps the heart contract a little bit more, which helps circulate the blood around, which helps wash out any of those kind of angry muscle products, hopefully gets more blood to the kidneys to help them keep going well. And it can also kind of deal with any angry free radicals that are made from all those nasty muscle breakdown products. So mannitol is a really good thing to consider giving when you have a patient that has been massively traumatized. This is not something we're going to give if we just have like a cut on an arm or a broken, even if it's a pretty broken arm. If we don't have our CKs climbing, then we don't really need to do this. But it is a really good idea in any situation where you're worried about all that muscle stuff breaking down and getting into the body. It is a diuretic, so it is going to make that patient pee a lot more. So you want to make sure you keep up with fluids in that patient so that you're not going to dehydrate the patient with the mannitol, but it is a very good thing to think about giving to your patients. And here is what we're hoping to avoid by giving our mannitol, giving our fluids, monitoring our patient really, really closely is what we had talked about was that vicious cycle. So if you just see acidic blood and a cold patient, and then their blood starts not clotting well, you're going to get that vicious lethal triad, and your patient is going to be very, very hard to save at that point. In human medicine, which obviously is not directly comparable, but I think is maybe the best data that we have out there right now. Here are some things that we have seen are more associated with death and more associated with that lethal triad. And those are things like trauma to your torso, the abdomen and the thorax, the acidosis, the coagulopathy, the hypothermia. So each of those things that we talked about in the lethal triad, and then also just getting hit where all of your important organs are, which makes sense. All of those, we have good data and evidence that shows each one of those issues increases your chance of death. Here's some little nice diagrams you guys can go back and look at if you're really interested in how exactly it happens that why clotting starts going wrong in trauma. Another kind of rare thing, but it definitely can still happen, thing when we have trauma is we can directly get bruising or trauma to the heart. So if we get crushed over our chest, if we get hit by falling debris right over our ribs, for whatever reason, we absolutely can get trauma to our heart itself. In really, really bad instances, we can rupture the heart itself. That is really, really not good. But you will be able to see it on your ultrasound. You'll see fluid in the pericardium around the heart, and you might see the chamber ruptured. But thankfully, that's pretty rare, not impossible, but pretty rare. But what is more common is when we give a really good whack to our heart just basically gets some scar tissue, gets angry, gets the electrical signals a little mixed up, because obviously our heart has to work muscularly, but also electrically all together. And so it is pretty frequent for us to just see arrhythmias in our heart after it gets hit directly. But we can also see arrhythmias in our heart as we start to get some of these other systemic issues from trauma. So I just thought I would go over very quickly. Probably the most common thing we would see on our ECG in a patient that has had trauma with a direct hit to the heart is what are called ventricular premature contractions. So that's basically when the ventricle, the lower part of the heart, kind of takes over and says, nope, I'm going to use my electrical signal to start the heart's squeeze. And obviously that doesn't work super well because we need the atria to squeeze and squeeze all the blood down into the ventricles first, and then have the ventricles squeeze the blood out into the body. So if the ventricles take over, things get very disoriented and disjointed. And so they can look different, these premature ventricular contractions, depending on whether it's the left ventricle or the right ventricle that has decided to start the party. But up here, we've got some right-sided ventricular premature contractions. Down here, we have some left-sided ventricular premature contractions. We have some of them happening together. In general, if there are only a couple of these contractions here and there, it's not necessarily something we have to do anything about. If they're always coming from one part of the heart and they're not super fast and it seems like the patient has an okay heart rate and blood pressure, it's just something we can monitor for a time. But if we have what are called multiform ventricular premature contractions, so that means they're coming from the right side and the left side both at the same time, or if we have what's called ventricular tachycardia, where these premature contractions are happening, then that is something that we need to worry about because that can lead to ventricular fibrillation, which is essentially just these squiggly lines that happen right before we die and are really not good. So the causes for this ventricular premature contraction are, this is the acronym in English, it spells HEADS. It's just a word that helps us remember the number, the causes, but heart disease. So if you have heart disease, like a valve disease or some sort of disease, or also just direct trauma to the heart, like we talked about, or electrolyte abnormalities, so lower high potassium, magnesium issues, calcium issues. They can all cause these ventricular premature contractions, and that can happen with the muscle damage from trauma. Adrenergic stimulation, or so basically your sympathetic nervous system getting really activated by your adrenaline, your epinephrine surging through the body, that can cause this to happen in your heart. Different drugs can have it happen. And then also the spleen, for whatever reason, seems to have a special compound that it will release that will cause the heart to be unhappy and have these contractions. And the spleen is pretty easily traumatized. If you get hit in the abdomen, your spleen is one of the first ones to kind of cry out and have a problem and start bleeding and releasing compounds. So, as you can see, there are many, many things. Basically, all of these things can happen in trauma and can lead to these abnormal heart rhythms. I did want to just point out there is this middle ground that can be kind of tricky where there's something called the accelerated idioventricular rhythm. So we're not quite at VTAC, but we're having these ventricular premature contractions over and over again. But the heart rate's not super fast, like 110, 100, 120. We don't necessarily have to treat these if the blood pressure is okay and if the animal is doing all right. But once the heart rate gets fast enough, and people are going to argue over what's fast enough, I can't say the exact number, but I would say over 120, over 140, definitely over 160, then we're going to need to treat our ventricular tachycardia. You're going to want to check electrolytes if you have the ability to do that. If you have lidocaine, we would want to treat with that. If that didn't work, we would want to try procainamide. If we have magnesium, it's always a good idea to give magnesium to try and treat it. But we want to try and do something to try to reverse these arrhythmias and prevent us from getting to ventricular fibrillation. Once we're in ventricular fibrillation, we need to treat that with defibrillation. So those paddles that shock the heart that we see on all the medical drama shows. And we're still going to want to try and check our electrolytes and all of those things to figure out why our heart is so unhappy. All right, we're actually making okay time, which is fantastic. Excellent, excellent. Obviously, another kind of very specialized part of trauma that I wish we could go into a little bit more, but we'll just cover a little bit about it, is traumatic brain injury. So obviously our brain is super, super important. Our patient's brain is super, super important, and our brain is really, really squishy and really fragile. So it definitely can get quite damaged with any sort of trauma. We can get what is called a direct impact injury. So if the patient gets hit right here, this would be a trauma called a coup trauma. And then if the brain bounces off hard off the other side of the skull, that would be called a contra coup injury. And you can get both, unfortunately. You can also get traumatic brain injury just from like abruptly stopping. So again, if the patient like fell and they kind of got whiplash, their head got knocked around a little bit, they might not have even gotten directly knocked on the head, but their brain got moved around really fast inside their skull, and it rammed against the inside of the skull and caused trauma. Or shockwave if there is some sort of earthquake or large building that collapses or something like that that releases a shockwave. Those are sometimes strong enough to lead to traumatic brain injury. So any and all of those things can happen. And as we have talked about before, if we are going to have to anesthetize our patient to perform all of our diagnostics and our treatments and things, then we as wildlife and zoo veterinarians are going to have to change the triage exam, change that sacred approach where we're doing respiratory, then cardiac, then neurologic, then genitourinary, and we're going to actually want to assess our neurologic system from afar first before we go in and sedate or anesthetize and then do respiratory and cardiac evaluation. Because once we anesthetize a patient, we're not going to obviously be able to fully get all of our neurologic information. So if you can from afar, try to assess, does this patient seem to have its cranial nerve functions? Is it able to move all of its different limbs? That's especially important because if it looks like we might have both our forelimbs and our hind limbs paralyzed or unable to move, then we also have to worry about, are the nerves that are actually utilized to move our ribs and our diaphragm to breathe, are those also affected? And are we actually going to find that this patient has a really high CO2 and is really not doing well once we get it anesthetized, because they just aren't able to breathe by moving all of those muscles. So that's all something that we might have to keep in mind. So again, just to remind you, if for some reason the patient is really severely out of it, sometimes with brain injuries, we maybe don't have to sedate it or anesthetize it because they are in a coma, they are obtunded, they are depressed. It is weird, but we're actually going to do the heart triage and the respiratory triage first, and then we will assess our brain. If it seems like our brain is hurt, then it's a good idea to try and give hypertonic saline to help try and decrease any swelling or inflammation that might be going on in our brain. And usually we would start with, in the US, we usually have 7.2% hypertonic saline. I don't know what you guys have available, but somewhere around 7 or 8% hypertonic saline, and give 3 or 5 mils over 10 minutes or so to try and decrease the swelling on the brain. And we would absolutely 100% want to give that hypertonic saline right away if we're seeing anything consistent with a Cushing's reflex, which we'll talk about in just a minute. And also, it is pretty common to have seizures after a traumatic brain injury, just like in our heart, where when you're getting directly hit, directly damaged to an electrical organ, the heart with its muscles and then the electrical signals. The brain is very, very similar. It is an organ that has a lot of electrical signals that are floating around. Those electrical signals can all get hung up around one area where they were hit, or if there's bleeding or actual damage to the brain, all of these things can make it so that our electricity just doesn't travel smoothly through the brain, and then that can lead to seizures. And so we're going to want to treat those very quickly with midazolam, usually 0.5 mg/kg, or diazepam. If you guys have levetiracetam or Keppra, that's also something that is really liked for seizures of traumatic brain injury. It is a little bit tricky because we would just have to decide what our cutoff is for our wildlife and what our goal is for them, because if this animal is something that we want to release into the wild, they may have seizures for the rest of their lives if they develop seizures secondary to a traumatic brain injury. So are we willing to try to rehab this animal and see if the seizures will go away? And if we are willing to do that, it's going to be a very long process because we typically need to keep them on the anti-seizure medication for several months and then wean them off that medication slowly for several months. Or is this going to be an animal that we try to keep in a sanctuary, and are we going to be able to medicate it daily for the rest of its life for these anti-seizure medications? So unfortunately, when we do see seizures, it brings up a lot of extra questions that we're going to have to keep in mind as we move forward with that patient. Here is a chart that you can come back and look at if you would like on the modified Glasgow Coma score. So in human medicine, they have the Glasgow Coma score. But obviously, in our animals, we can't be talking to them and asking them questions and asking them to answer them to us. So we have a modified coma score that we utilize to help us characterize how alert and oriented and how neurologically normal a patient is versus how um, obtunded, depressed, comatose that patient might be. And as I alluded to earlier, if we have what we think is a traumatic brain injury, we are really going to want to be monitoring for a Cushing's reflex. If we have, where did my thing go? Who knows? Okay, well, I don't have my slide yet, so I'll just have to describe it. But when we are looking at our patient and assessing their neurologic system, we're looking at their eyes. Again, obviously, there's a lot. A full neurologic exam is really important. It's really exciting and interesting to help us localize where everything is. But if we want to just be really, really simplistic, because we don't have a lot of time in this lecture, and also because maybe we have a ton of things going on, maybe this is a disaster where we have multiple patients all coming in at once, we don't have time to be doing a perfect neurologic exam on 50 patients that come in. On a most simplistic sense, we are wanting to look at patients and look at their eyes, and we want to see um, are their eyes really big, have really big pupils, or have really small pupils, and do those pupils respond to light? And in general, if those pupils are what's called mydriatic, so the pupils are really, really big, and if those pupils don't respond to light when we shine them, they don't have a pupillary light reflex, they don't constrict down when we shine light in them, either in one eye or both eyes, that is very concerning. And that tends to correlate with some severe brainstem damage, which might be um, actual direct damage to the brainstem, but that's pretty rare because the brainstem is in the middle of the brain. There's the skull and then the brain, and then the brainstem's deeper in there. So it's pretty rare to get trauma directly to that. So more likely, if we're seeing these really mydriatic big pupils that are not really responsive to light, more likely what's happening is that the brain is swelling a lot, and that swelling is pushing the brainstem out and back out of the skull and towards the foramen magnum. And if we all remember, if we do what's called herniate our brain, if we get so much swelling in our brain that we push our brain and our brainstem out that foramen magnum, we die. It cuts off all of our blood and everything, and our brain can no longer function, and we die, and our patient dies as well. And so I'm sure we all learned this, but we're just going to remind ourselves really quickly. Your skull is a really, really small case, a very rigid case for your most precious brain, or your patient's most precious brain. But there's just nowhere else to go. If there's any swelling around your brain, then there's no room because the skull is made to be perfectly sized for the brain. And so then if you have bleeding, if you have swelling, if you have anything extra added to your brain, then that's a really big problem. And it does start pushing that brainstem towards the back of your skull. And you have to maintain a good blood pressure to get blood into your skull. But when you get extra stuff in your skull that's pushing on things, then all of a sudden you can't get blood into your skull to supply blood to your brain. And that is a really big problem because your body obviously recognizes that your brain is one of the most essential organs and it needs to get blood and oxygen to it no matter what. And so what it's going to do is then create a really, really high blood pressure to try and overcome that increased pressure in the brain to really spurt that blood into the brain so that some blood with oxygen and good nutrients can get to the brain. But your body, in order to actually overcome that high pressure, is going to make that blood pressure super, super high, like 180 or 200 or 240 millimeters of mercury high. And that blood pressure is so, so high that your heart really, it can't pump against those really, really constricted high blood pressure blood vessels very easily. So it has to plummet its heart rate. Your heart rate goes down to only 30, 40, 50, 60 beats per minute, because it's so hard every single beat of the heart to push against those really hard, high blood pressure blood vessels. So if you have a patient that is not with it, if it doesn't have a good state of consciousness, if it is in a coma or is stuporous or depressed, and you see that it has a really high blood pressure and a really low heart rate, that is called a Cushing's reflex, and that is really not good at all. That means that it is minutes from herniating its brainstem and dying. And at that point, you need to give that hypertonic saline right away, emergency, in order to try and prevent it from herniating. And then once you do that, if it responds well, then you're going to have to talk about, do you need to do a craniotomy and pull off part of the skull to let the skull breathe, and let the brain have some more room? Do we need to let that animal pass away, euthanize it because it is so severely affected and we don't want it to be in pain? All of those are very good questions to ask and think through, but that is one scenario that we would deal with. What we really would like to do, though, is find out if that patient has high intracranial pressure before we see a Cushing's reflex. Cushing's reflex is literally minutes from death. So if we could find out beforehand, that would be much more helpful. And then we could do things like you can sit the patient up to help drain fluid out of their head, usually at a 30 or 45-degree angle. We can give that hypertonic saline. We can help keep their end tidal CO2 if we have them intubated low to try and keep the pressure in their head low. There are a lot of things we can try to do. So, of course, as I always do, I have some ultrasound that we could do that can help us with that. And actually, interestingly, if we ultrasound the back of the eye, it can really help us assess our intracranial pressure. And all you have to do is close the eyelids and put some gel on the eyelids so you won't damage or injure the eye at all. And you put your ultrasound probe over your eye. This is also helpful in trauma because sometimes if they get hit really hard on the head, you might actually get retinal detachment, and you can see a retina detached on your ultrasound if you see that, or if they have high blood pressure and it detaches their retina, you can see that as well. In humans, you're going to look at their eye here. It looks like a healthy eye because it just has normal dark fluid, but if you were to see things floating in it or light stuff in here, that might be blood or pus, or again, the retina detached or anything like that. And then you're going to come back through the eye and you're going to see the optic nerve. So that's cranial nerve coming out into your eye to supply the nerve signals to help you see. And in humans, if the cranial nerve measures greater than 5 or 6 millimeters, then you know that you have increased intracranial pressure, because there's fluid in there that's expanding the optic nerve. I don't know what the number would be in an orangutan, but obviously we should probably start doing this in our anesthetized patients if we're experiencing a lot of traumatic brain injuries, so that we kind of know what normal looks like, and then we can compare it and maybe we could get measurements. But even beyond that, even if we don't know what a normal measurement is, one thing we can look for is what's called optic disc or optic cup elevation. So all of these patients here are abnormal. Normally, your eye should be a completely round circle and there should not be any little hump here into the eye where the optic nerve comes into your eyeball. It should be completely flush and completely no bump whatsoever. But the fact that we can see the bump here in all of these means, again, that there's increased pressure. It's something called papilla edema. So there's fluid in the optic nerve that is pressing out from our brain that's swollen. And so it's popping out into the eye a little bit. And so this is a useful ultrasound thing that we can do. to give us a hint on whether our brain is overly full of swelling. And so definitely something I would recommend for us because, um, in dogs and cats and in humans, they can do a lot of testing, a lot of neurologic testing, a lot of cranial nerve tests, a lot of asking a human questions and asking them to answer those questions that really helps them figure out their neurologic status. But with our animals, if they are aggressive, if they're wild, if they are not able to tell us what's going on with their neurologic system, then we're going to have to find workarounds and figure out what we can figure out just from other tests. And so I think it's important for us to think about ultrasounding their eyes, for example, to assess what's going on in their brain. And another thing to keep in mind or to know about our traumatic brain injury, if and when we have a lot of brain swelling, unfortunately, our brain controls so much in our body. And so we can see so many problems throughout the rest of the body because our brain got damaged. As we talked about earlier, sometimes we see our temperature do crazy things because our brainstem is damaged and we're not maintaining a normal set point in our body anymore. And our body doesn't realize what normal temperature should be. So that patient might look like they have quite a high fever one day and then quite a low body temperature one day. We can also see what we would call neurogenic pulmonary edema. And so sometimes when the very center of the brain gets really rattled, either with a really hard hit or a really bad seizure, just like if you guys remember, we have cardiogenic pulmonary edema, which is edema that comes when our heart is not pumping very well and things aren't going very well. But we also have non-cardiogenic pulmonary edema. So this is edema or fluid or swelling into our lungs because of a different reason, not because of our heart. So choking is something that can definitely cause this. We can definitely see this in that smoke inhalation if we have so much swelling to the upper airways that we're really struggling to breathe and we are basically choking. We can see fluid in our lungs from that, from just working so hard to breathe. But also, we can absolutely get this almost instantaneously with our brain getting traumatic brain injury or having a seizure. It's called neurogenic pulmonary edema, and it truly is just a certain part of our brain getting stimulated and releasing hormones saying like, oh my gosh, we need to freak out. We need to release a lot of catecholamines. Something is not right. And then all of a sudden we get all this fluid in our lungs and we're really struggling to breathe. And it's not even that there was any lung damage. It's just that our brain was damaged and sent the wrong signals out into the world. So that can unfortunately be something we see. Once we have a traumatic brain injury, it is so hard to decide how to interpret all of the different data points and signals that we get from our patient's body when we're measuring things because we just never know what the brain is misinterpreting or what bad signals this brain it might be sending to the body. And there are things such as what's called the syndrome of inappropriate ADH release, which will make the body make incorrect urine concentration. So even though our kidneys are supposed to re uh, respond appropriately to us being either dehydrated or overhydrated and make the correct amount of urine, our brain, if it's really damaged, might not let us do that. And that also can be a really big problem when we're trying to support this very injured patient where we have to give it, like I said, lots of fluids, maybe some mannitol. We're trying to manage all of that. And then if we have a traumatic brain injury on top of it, it might muddy the waters even more. So if you guys remember some of the talks that we had about fluid therapy, as much as we possibly can, where we are monitoring weights, we're monitoring how much fluid is coming out in the urine, either by weight or by volume or by just visually looking as much as we can, checking our urine specific gravities on there, checking electrolytes. If we have that capability, it can all be super helpful to try and give us as much information as possible about what's going on inside of our very ill, traumatized patient. All right, so that is a very, very quick whirlwind overview of some things that can happen with trauma when there's really, really severe trauma. I did just want to have one very quick slide. Unfortunately, as you guys have already asked about and is really, really important, pain management is so, so important for patients that are experiencing trauma, disaster type situations, and that would be more than a talk on its own. So I don't have a ton of information or a ton of time to go over anything, but I did just want to point out this kind of cycle that we know about in traumatized patients and in patients that experience severe injuries. And this is basically, not only do they have the pain of the trauma, kind of what we would call background pain, but then they might get breakthrough pain, if they're having to move a limb that got broken or are having to move that burned area of their body that might break through and cause more pain for them. And then they are unfortunately going to have procedures where they get their bones set or where they get their eschar cut off or where they get their wounds cleaned, and that can increase the amount of pain there. And then they can have post-operative pain as they're trying to heal those wounds or do anything, and then that can all lead to chronic pain. So as best we can, it is really helpful to try and think of the pain from all of these different areas and think about like, okay, how are we treating background pain? Is there anything we can do to treat breakthrough pain? What increased pain can we give for procedures and post-op times? And is there anything we have on board for chronic pain? And so again, we don't have time to talk about this a lot or anything, but I did just want to mention we do want to try and think about giving them as many different kinds of pain options as we can. So if we have opioids, those can be really helpful. Non-opioids, if that patient is healthy enough to receive them. Sometimes they are too sick to receive non-steroidals or acetaminophen. Sometimes we can give them gabapentin or other gabapentinoids. Dexmedetomidine, if you have that at a low dose at a CRI or intermittently, can be very, very helpful. Ketamine is really good for wind-up pain and chronic pain. Anxiolytics can also help with pain. They are obviously not treating the pain directly, but if they're going to get more anxious about a procedure, if they know that something is going to be painful at a procedure, sometimes helping decrease that anxiety can help decrease wind-up pain. Also, obviously, anything we can do to decrease their stress or provide them with enrichment. And also, sometimes we need topical treatments like aloe or any sort of other topical treatments for itching. Sometimes itching, as things heal in our skin in wounds, and that cathepsin G comes in during the healing portion. I think we've all experienced that where we're having a wound heal and it's just horrifically itchy. That can also be super, super unpleasant and lead to increased pain. So that's something we probably want to keep in mind as well. So that was a lot of random things. I did want to just mention also local blocks can also be really helpful. And we don't have time to go over this today, but I would say the best bang for my buck I have as an emergency and critical care doctor and for my local blocks is intercostal blocks. You can use your ultrasound or you can not do it with ultrasound. You can definitely do it just by palpating your landmarks. When you have broken ribs, when you have pleural effusion, when you have anything in the thorax that's painful, blocking those nerves around the ribs and helping that patient not feel that pain can really, really, really help. So definitely would recommend utilizing that. It is a pretty easy procedure that you all could definitely teach yourself. So anyway, again, that was quite the whirlwind of a lot of very random information, but it all hopefully was something, a little teaser to teach you a little bit about what you might be considering or keeping in mind when you have a really, really traumatized patient that has a lot of issues going on. And I think I'm 4 minutes early if you guys have any questions for me. And I have more slides here for you to look over in the future if you want to.
Thank you very much, Lily, for the very great informative presentation. Anyone has any question for Lily? Any questions? Yes, we have one question.
Okay. Hi, Lily. My name is
Hello.
Patrick. I want to ask about acute kidney injury and about rhabdomyolysis. Maybe two questions. The question is number one is, since myoglobin can cause tubular obstruction and direct renal injury, is monitoring urine color and urine output sufficient for early detection of acute kidney injury, or should we rely on additional biomarkers? And the second one is, in wildlife with several muscle trauma, where laboratory monitoring may be limited, what practical field indicator can help us recognize rhabdomyolysis associated acute kidney injury before irreversible renal damage occurs? Maybe that's the question.
Yeah, all very, very good questions. So, I would say as hard as it is, because believe me, I have my patients here at my hospital, and it is not easy with all of our doctors and nurses and all these different patients all running around. But I agree with you. If you can watch the color of the urine and how much urine is being produced, and even again, check the USG, that is going to be super, super important for monitoring for acute kidney injury, because if you have a color of urine that you don't like that indicates that there's myoglobin in it, then you know that you're at risk for kidney damage, and you're not going to see your kidney values increase. And so those are your blood urea nitrogen and your creatinine. Those are not going to increase until 75% of your kidney is not functioning normally. And so obviously we still would like to monitor our blood, because if we do see our kidney values going up and if we see our electrolytes going off, we would like to fix those so that we can support the kidneys as much as possible. But if we don't have that available, or if we are, having to wait for blood work to come back because we have to ship it out and wait for results to come back, we can get a lot of information by just monitoring that urine. But it can be hard to kind of catch every bit of urine, because little mills can dry up or can get caught in towels or can be caught in wood wool or enrichment that we give an animal. So it takes a lot of work to try and make sure you've hunted down every spot and looked in every spot to try to evaluate that the urine output. But yes, if it looks like only 1 or 2 mils per kilogram of urine is getting produced, or if it's really a bad color, or even if there's a ton of urine getting produced, like way too much, way more than you would want, but it looks kind of dilute, maybe you'd want to centrifuge it, spin it down to see if you're seeing any myoglobin or blood coming out or anything like that. So yeah, I would monitor that really, really closely. And if you don't have the ability to watch the blood values very easily or very quickly, again, your blood values aren't even actually going to tell you that until your kidneys are pretty damaged. So I would watch your urine very closely. And then for your rhabdomyolysis, that is really, really hard to find, even if you have tons of resources. Even the human hospitals that have all the money in the world, they're doing really fancy CTs and MRIs, and they're not always finding it. So I guess, again, I would really try to keep an eye on your urine, and I would also just use your really good physical exam findings, palpate and compare one bicep on one arm to the bicep on the other arm and see if they feel differently. I don't mean to be obsessed with ultrasound, but ultrasound can also show you. You can see if the muscle looks different and it looks like it's dying. You can also see if you have a fancy enough ultrasound that shows you blood flow, which most ultrasounds do. You can see if blood is actually able to flow into that portion of the muscle. But you can also just touch it, feel if it feels cold. If you have infrared cameras, you can look and see if that looks cold or not. Another thing you can try if you really need to is if you have a glucometer or a lactate meter, those just small little handheld ones, you can kind of prick an area where you think it might be dead and then also prick an area where you think it's healthy, and you can test the glucose and the lactates and compare them between the areas, because if it's a very dead muscle, it's not going to have any glucose and it's going to have a really high lactate, and you can compare it to another part of the body that maybe is healthy and getting good blood flow, and it should have a normal blood glucose or higher blood glucose and a lower lactate. So that might hint that something isn't right. But certainly even the human doctors with all of the fancy tools and all of the money it's not always easy for them to diagnose rhabdomyolysis.
Okay.
Thank you very much, Lily. Any other questions? No? No? Yeah, I guess that's all for Lily's session today. And for your information, it's 3 a.m. at Lily's place now. So, yeah, a big thank you to Lily for those great sharing, and also big love and big hugs from us from Jogja. So now it's coffee break, 3:30 p.m. and we will get back here to the room at 4 p.m. Okay? So see you guys again at 4 p.m. for the next session, for the last session with Steve. Okay? Thank you very much, Lily. See you guys.
Bye, everyone. Miss you all. Have a great rest of your week.
Thank you.